Greetings. Let us talk about foreign body retrieval using an endoscopy cap. These are my acknowledgements, and we will learn about the use of an endoscope cap, especially for removing foreign bodies. At the same time, I will also comment on how to use a cap for routine colonoscopy or endoscopy. And then we will learn about how to apply a cap at the end of an endoscope. So here you see a plastic cap, and the tip is not traumatic, and you see a side hole that allows any fluid that accumulates in the cap to drain spontaneously. And it is important to make sure the application of the cap is done properly, keeping in mind where the side hole should go at the end of an endoscope. So let us learn about that. So you place the cap, you moisten the cap, and then place it at the tip of the endoscope and make sure that you press it down so that it anchors to the tip of the endoscope. And some endoscopists, depending upon how much cap is protruding beyond the scope tip, may fix the cap to the endoscope with a tape. And now let us figure out where the side hole should go. So you see the side hole, and this should go away from the biopsy channel. And I will explain the rationale why they should be on the opposite side of the biopsy channel, away from the biopsy channel. So let us look at the tip of an endoscope. Here is the endoscope. You can recognize the biopsy channel at 12 o'clock. We place the cap or attach the cap to the endoscope, and it is important to have the side hole away from the biopsy port, exactly at least at the opposite side. So what happens is, as you're doing an endoscopy, especially if you're using the cap for a colonoscopy procedure, if fluid accumulates in the cap, it is very easy to drain it if it is close to the biopsy channel. On the other hand, if the fluid is accumulating on the other side, then the biopsy channel will not be able to drain it without suctioning and collapsing the lumen. And by placing the cap in such a way that the side hole is away or at the opposite end of the biopsy port, if the fluid accumulates in that area, being that a dependent area, the side hole will allow the fluid to drain out spontaneously. So this is very important, especially when you use a cap for either screening endoscopy or for screening colonoscopy. The cap is applied to the end of the scope by about 2 to 3 millimeters away from the tip of the scope. That's ideal. If you want to enter into the ileocecal valve, or if you're working on a polyp that needs resection and the polyp is located on a fold and it goes into the valley on the proximal side, then I place the cap and protrude it at least 3 to 4 millimeters instead of 1 to 2 millimeters from the tip of the scope. That would allow me to sit on the top of the fold and look down and be able to access that lesion much better. In addition to the use of cap for screening endoscopy, the cap is also used for foreign body retrieval, and we will come to that. I routinely use the cap for examining the lower portion of the rectum and the anal canal. Once I finish the colonoscopy, I try to take the scope out and pull the cap out a little bit out of the tip of the endoscope so that it is a longer cap, and then introduce into the anal canal and use that almost similar to what we do with anoscopy. A longer cap would allow me to stabilize there and have a good exam. You could do the same thing when you have a lesion in the duodenum and you're popping back into the antrum repeatedly. You can make your cap protrude out a little bit out of the endoscope so that you could use that to anchor onto the pyloric ring and examine the duodenum and be stabilized there for whatever endoscopic therapy you want to achieve. So these are some of the things that I want to share with you in terms of how to use a cap, how to put the side hole, where the side hole should be, and how much of cap do you put at the end of the scope. It's 2 millimeters for just screening exam, 3 to 4 millimeters for therapy, or examining the lower rectum, anal canal, or the duodenum. If you have a food bolus obstruction in the esophagus, you could apply the cap, or in some cases we use a band ligator cap which has got a longer barrel and go down in the esophagus, suction the food bolus, and then pull it out. So something to keep in mind in terms of the various uses of cap and application of the cap. The length of cap that should be beyond the scope, and the location of the side hole away from the biopsy port. Thank you.